Well, good afternoon, good morning to everyone. Thank you all for joining. We are live on Facebook and we are here for, I think, what will be an incredible conversation. And we're so glad that many of you have joined us. And we're going to give everyone a few minutes to get started as I just kind of do some introductions and tee up the conversation we've got today. I'm very excited about this. This is another installment of our Healthy Moms, Strong Babies webinar series that we started. We really started this during coronavirus, and when we found the need to really have to get to a lot of women with a lot of information, we decided to do a weekly webinar series, and it's proven to be incredibly valuable to a lot of women and healthcare workers and so many different people who have been struggling to get answers around how COVID-19 would impact pregnancy, childbirth, and a whole range of questions affecting women, pregnant women, women that just had new babies. But even as the world turns, so to speak, and as the world has evolved, we've added new levels of challenge in this country. So on top of a global pandemic, we've now added a renewal and a reminder again of the daily truths that exist for so many people of color in this country around the hard reality of racism and how that impacts our daily lives in so many ways. And so today's webinar is really around confronting the hard truths, how systemic racism really affects moms and babies, issues specific to the work of March of Dimes and so many of our partners. And what we've done today is invited several of our great friends and colleagues and leaders and experts in this area to talk about and really have an honest conversation about the effects that racism, systemic racism and chronic stress have on moms and babies. We know that it has a tremendous impact on the health of women, the health of their newborn babies. And we think it's really important that everyone understands exactly what it is, why it is, and what we can certainly try to do about it and how we can try to address it as a country. So this is going to be a slightly different conversation, but it's timely. We have had conversations already through this around the impact of coronavirus and disproportionate impact that COVID-19 has had on communities of color and what that means for women of color and babies of color. But specific to this issue of racism generally, I'm looking forward to what we're going to be talking about today. I want to say that each week that we've been able to do this, it's been because of the very, very generous support of a great partner of ours, and that's Merck for Mothers. They have provided great support and great funding to the March of Dimes in order to bring this kind of content, to be nimble in how we bring the content to you all. And before we get started, I just want to introduce you to Marianne Etzebay, who is the lead and executive director for Merck for Mothers. And Merck's made a tremendous investment in global health issues generally, but certainly as it relates to moms and babies. Their whole mission has been to create a world at Merck for Moms where no woman has to die while giving birth, making sure that all women are healthy and babies are healthy as possible. Between 2011 and 2019, Merck for Mothers maternal health programs and partnerships have resulted in healthier pregnancies and safe deliveries for over 10 million women in 48 countries. And we're just so, so pleased that Marianne has agreed to join us today and just bring us a few words of welcome. Marianne.
Thank you so much, Stacey, and just thank you for the opportunity to be part of this conversation. It's the conversation that we must have. You mentioned our mission to make sure we're creating a world where no woman has to die giving life. And I think it's not just the events of the past weeks and months that tell us all. It's not about what we do outside of the US, it's what we do right here at home, where we know Black women are 3 to 4 times more likely to die during pregnancy and childbirth. And this just cannot continue to happen. We can't let the COVID-19 pandemic actually make those disparities in maternal health outcomes worse. And we need to get at the root of it. It's not just maternal mortality being a vital sign of our health system, it's being a vital sign of our society. And I know that that's the conversation you are wanting to have here today. And it's just an honor to be able to help build and grow, these communities of connection that we all need. I just want to end by sharing something. Jackie Caglia, who actually leads our work in the US, she shared a quote with me from James Baldwin, which is, "Not everything that is faced can be changed, but nothing can be changed until it is faced." And I think, Stacey, that's the conversation you want to have, facing and confronting those hard truths around the underlying the pervasive systemic racism that underlies these disparities that we see in maternal health outcomes. So thank you for creating this space for all of us.
Thank you, Marianne, and thank you again so much for your support. And we are so grateful for everything that you're doing, because you're helping a lot of organizations, and you and Jacqueline are just an amazing team, helping so many of us in the U.S. and around the world address some of these pressing issues. And as you know, as Marianne mentioned, we are living in unprecedented times, as we talked about. We have a global pandemic that's placed expectant mothers and new moms in just under a great deal of stress and anxiety, like many of us have never seen in our lifetimes. And then on top of that, now we are again reminded through all of the social unrest that we are experiencing right now, that we have been facing in this country generations and generations of a history of racial injustice. And it is important to really understand how these issues of racism really do lead to some really unacceptable outcomes with respect to women of color, especially African-American women of color, and babies, where Black women, as we mentioned, are 3 to 4 times more likely to die as a result of pregnancy and childbirth. Black babies are twice as likely to die as white babies as compared to white babies before their first birthday. And I think this conversation is really going to be able to pursue is really this idea of how racism plays out in our healthcare system, how it shows up. Sometimes it's hard for us to have the conversation because we can't even describe it or understand it when it's going on. That's kind of the insidious nature of racism, though, which is that it is pervasive, as Marianne, you said. It shows up in our policies. It shows up in how our institutions behave, how people may behave, how people show up in terms of how they treat others who show up for care. And I think it's important to look at all of these issues, and that's what we're going to do today. We do think that if we face these challenges, Marianne, that we can actually do something about them, that we can actually work harder to advocate, to promote safe and equitable care for all women, for every mother, every baby, to deal with the issues of racism and chronic stress. If we talk about them and really face them, we think we can actually start to work on them and change the outcomes that we're seeing today. But it's going to require a lot of hard work, and it's going to require not just conversation about it, it's going to require some action.
Yes.
But today we're talking about
Yes.
really what some of the issues are and how do we enlighten a lot more people around some of these challenges. So we are at the March Times doing everything we possibly can to be a part of working with others to address these issues. I don't think there's been a time in our history at the March Times when we've been as vehemently vocal about these challenges and trying to confront them and doing things beyond just talking about them with our implicit bias training programs. We have a new Beyond Labels website that is not new, but actually working with CDC. We have a Beyond Labels website that I think is probably going to be in the links or in the comment section on Facebook Live. That you can go to really understand more about what we're doing to address disparities and the stigma that often exists and that women often have to deal with respect to care. And certainly in our policy and advocacy agenda, we're doing so much. And in our programs as well, with supportive pregnancy, which is an evidence-based program that really does help women of color have successful and healthier pregnancies. So there's a lot we've done. There's a lot more we need to do. So let's just get into it right now and start the conversation. And we are going to be talking about bias and the effect of healthcare, its effect on healthcare. We're going to talk about the history and the reality of racism. And I want to introduce some of our panelists who are here joining us, a very distinguished panel of really good friends and women that I admire greatly. I'm going to start by introducing Dr. Joy Creer-Perry, who a lot of people know in this space. She is one of the biggest voices and the greatest minds in this space. and has been doing this work for a long period of time. She's the founder and president of the National Birth Equity Collaborative. She's an OBGYN and a fellow of the American College of Obstetrics and Gynecology. She's a thought leader around racism as a root cause of health inequities. She is from New Orleans. She worked in the New Orleans and helped to lead the New Orleans Health Department. She's got an amazing array of awards and recognition for her work. And I want to thank Joya, Dr. Career Perry, for joining us today. The next person I want to introduce is Dr. Talia Coney. She's a National ACOG Junior Fellow College Advisory Council Vice Chair, the moderator of ACOG's Congressional Briefing on the intersection of COVID-19 and maternal mortality. She's a fourth-year OBGYN resident. She was on call yesterday, but got a ton of rest last night, so she's raring to go today at the Medical College of Wisconsin, and she's on the front lines in Milwaukee on the issues of maternal and infant care. So I want to thank Dr. Coney for being with us. Next, I want to introduce Dr. Kimberly Jeffries Leonard. She is the president of the Links Incorporated. I am a member of the Links, a proud member of the Links, and the Links is one of our nation's oldest and largest women's volunteer service organizations with over 15,000 professional women, primarily women of color, Black women, African American women, and others, in 288 chapters across the United States, the Bahamas, and the UK. She also served as Deputy Director of the U.S. Department of Health and Human Services Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration. She was the Chief Operating Officer of the District of Columbia's Department of Health and has a tremendous background in public health. So Kimberly Jeffries Leonard, thank you for joining. And we're so happy to have you. And then last, but clearly not least, is Nina Martin. Nina is a reporter and an editor who specializes in women's legal and health issues for more than 30 years. She is a prolific author. She has written articles for ProPublica, investigating maternal care and preventable deaths. She did this work as one of the pioneers in media, really bringing attention to the issues around maternal mortality and morbidity. She has also written for the Baltimore Sun, the Washington Post, the International Herald Tribune, and magazines such as Health and Elle. So Nina, we're so pleased to have you joining as well. I'm going to serve as a moderator, and I'm going to get into it right now. I'm going to actually tee up the first questions for Joya. Joya, I think it's really important, and I certainly have heard this in as we've started to raise these issues around the impact of racism on health outcomes for moms and babies. I think a lot of people really need a sound evidence-based understanding of this. Beyond what it feels like to live the experience, can you talk a little bit about what we know about how racism actually shows up in the healthcare system impacting moms and babies? What does research tell us? What do we know to be true as it relates to some of these issues that we're seeing?
Yeah, so thank you so much, Stacy, and to your entire team, and to Marianne also as well for having this a very important conversation. Honestly, if both of you had not made room for these types of conversations, it wouldn't allow us to do the work that we do. So I really do genuinely appreciate you both. So thank you. So as you mentioned, Stacy, a lot of the times when we're doing anti-racism trainings or implicit bias trainings, we start with just some level setting on what the word racism means. So many people, when I say the word, and when we say the word racism, they get nervous, it makes their heart race, because they think that it means a slur or a bad word, or I'm calling them a bad name. But really, this a hierarchy of a belief in human value based upon skin color is not a slur, it's not a bad name, it's a historic and a current fact that we've codified that in laws for generations, for hundreds of years, that it's been a part of our institutions, this belief that certain people have more value than others. And so even when we take the laws away, that value is still underlying inside of how we provide clinical care. And so our bodies then respond to that. And I'll give you a concrete example of something that really has come up recently in OBGYN. There's a lot of conversations around the VBAC calculator. You might have heard that. If people had a C-section before and you want to have another baby, there's a calculator that was created to see what your risk is of being able, your opportunity or risk of having another baby through a C-section or not. And that in there, they calculate that and they use race as one of the determining factors. But we know that the reasons that Black women and brown women are more likely to have C-sections are based upon provider bias. Our pelvises are not different shaped. We don't have android shaped hips, but that's what was taught in medical school for so long. So when you try to explain to providers that there was never a truth that Black people have different shaped hips, and so when you create a calculator based upon race, that in itself is codifying and institutionalizing a racist belief and bias. And that's how healthcare then has people who look like me come to the hospital to have a baby, and they're told, because you're Black, you should have a C-section because this calculator says so. And that's the ways that racism and racial bias shows up in healthcare.
And talk about that a little bit more in terms of the history of it, because it's not as if these issues just all of a sudden showed up. You know, I wrote a piece in Medium just in the past week or so, and you know, really talked about in that history of 400 years, we've actually never had a healthcare system that delivered quality, equal, equitable care to people of color in the history of this country.
Right.
And so in some ways we shouldn't be surprised that we're seeing some of these disparities that we're seeing, but can you talk a little bit about that? Because I think our understanding of history and how this country has evolved isn't always as clear to people as maybe we can make it.
Yeah, for sure. And I think it's really important because the reason I honestly don't use the word health disparities, I say health inequities instead, is because of this history you're talking about. Because in history, the reason, the belief that we are different was that we were biologically or genetically different. And so much of our healthcare, I mean, if you think about the beginning, even Darwin's original books, people love to quote Darwin, survival of the fittest, right? But the rest of that title says the better race will be of prosper. And he believed that by now the entire world would be white, and all Black and brown people, indigenous people, peoples from South Africa, South America would be gone. So we have not had an honest historical conversation about the underpinnings of our healthcare industry, of the work that we do. If people knew as an OBGYN, we weren't trained that the founder of gynecology, J. Marion Sims, traveled around the country with 3 Black women who were enslaved, Lucy, Betsy, and Anarcha. And he did surgeries on them, multiple dozens of surgeries without any anesthesia, even though anesthesia existed at the time. And he said, well, they could survive these surgeries because they don't feel pain the same way. And he wrote that in textbooks. And that was taught to people who are providers and physicians and nurses for generations, that we just feel pain differently. Our skin is thicker. And then even recently in 2018, studies show that providers still have those same beliefs. So they still do things holding on to this belief that we're biologically different. We have a different calculator for lung capacity, for kidney capacity, all those ideas that I have. I mean, my daughter did our 23andMe, and so I know I have Irish genetics, but people don't look at me and say, oh, you get Irish diseases, right? But magically, when you have brown skin, we magically equate that to mean that we get all these things based upon that brown skin. So it's important for us to really undo this belief that biology is race.
So does it mean that, so I want to come back with another question later, but, and then I also want to pick up with Talia about the training, because she's going through training as a medical student, so she can give some even more insight about that. But Joy, just the last question before we move on to that. There's this idea of weathering that has been looked at and been researched. And that we know that there's a connection between weathering and some of the outcomes that we're seeing that are affecting Black and brown women and moms. Talk just briefly about weathering, what that is, and where that comes from, and how we should think about it in the context of this conversation about racism.
And I love researching and looking to kind of where that started. So when Dr. Geronimo started this idea around weathering, I was really thinking about that. Although we as Black women, we have all these saying, Black don't crack, right? We look great. So we're like, how could we still have higher rates of hypertension and diabetes despite looking fabulous and having a great life? And truthfully, the weathering, your body's impact of racism with the constant daily microaggressions or even macroaggressions, your body is in a constant state of high alert. So if, as a provider, when you're seeing a patient who has lupus, you tell them your body's fighting to stay alive, and the lupus is also fighting you. And so your body is struggling to say, which one is more important? I got to hold on to me. So if you're pregnant, you're more likely to miscarry. You're more likely to have high rates of maternal morbidity if you have lupus. That's the same thing that happens to Black and brown folks when it comes to racism. Our bodies are fighting to survive. We're always on high alert. So when you're always on high alert, your catecholamines are rushing, your hormones in your body, you can feel that flight or fight it's always on high alert. You're waiting. And so that's going to make you have higher rates of hypertension. That's not about crossing the slave trade and holding on to salt hundreds of years ago. That's yesterday when I tried to cross the street and was worried about what happened to my neighbor. This constant threat of being devalued is internalized in our bodies. And I do think it's important for us to be proactive about not just looking at ways to fix the individual people because they're having this weathering, but to fix the system to not make us weather. I don't want my children or my grandchildren to say, oh, well, let's look at their epigenes and see how we can get a shot or a pill to fix the weathering. What we need to do is fix the causes of the weathering.
Right. So this idea of weathering is your body with the stress, constant and chronic stress that people of color experience in this country because of any number of acts of discrimination or racism that we all have to encounter in our life, that does have an impact on our health. And by the time you decide to get pregnant, not only could it impact your health, but it can impact the health of your baby as well. And that concept that's been looked at with research and evidence was really eye-opening and very enlightening, I think.
Yeah, I mean, we have studies that show that our telomeres are elongating, but you also have that same kind of evidence when it comes to surgical residents, women who are doing general surgery, because they're stressed a lot, they have higher rates of having miscarriage, and they have higher rates. So people can see it in high stress jobs, but they haven't been able to translate is being a Black person in America is the same as is not the same. It's similar to having a high stress job. We are always on high alert. We're always worried. We're always worried about our children. And so that is a thing. It's like being a general surgery resident for 75 years, right?
Right. So thank you for that, Joy. Now we'll come back to you, and I want you to chime in some more. I want to turn it to Talia. And Talia, Dr. Coney, you are again a fourth-year OBGYN resident at the Medical College of Wisconsin. You're in Milwaukee, Wisconsin. You mentioned to me earlier, it's considered one of the most segregated cities in the country. You're on the front lines of maternal and infant health care. Tell us what you're seeing in Milwaukee as you're treating patients, especially women of color. What are you seeing, and how are you seeing the impact of racism and bias and how that's playing out in your community where you are and with your patients?
Absolutely. Thank you so much for having me. As a fourth-year resident, I am seeing women in this community who have had significant difficulties due to the biases that their providers are putting on them. This would include women who have to take 3 bus rides to get to their appointments, but get there late and then are told that they cannot be seen. That's a bias, right? So as soon as they walk into the door, we have to recognize as providers that we come with our own implicit biases, and we have to keep those in check because they can drastically impact our patients and drastically impact our patients' care. And while I recognize that there's been a lot of studies in Milwaukee, and people talk about the implicit biases and how segregated Milwaukee is, from my standpoint as a resident, I definitely have not seen the amount of training that needs to happen and for providers in my residency program and probably in others to really talk about these issues that are happening in our communities, to really talk about how my biases can affect my patients and how our institutional biases and our institutions that may require a mother and her partner to show a government form ID before they even can come to their appointment, how that bias is preventing care. I think that with everything going on in the country now, people are recognizing it and trying to figure out how we can address these issues. But these are long-standing issues that in many communities and many institutional academic centers have been struggling with.
And it's interesting that you say there's not enough training that's going on. Do you, when your, say, white colleagues that are in training along with you, how do you see that show up? And have you seen examples of where you've seen maybe where their implicit bias has affected care? Or in conversations, have you been in conversations with people where it's clear they may be, they may have some implicit bias? Of course, having implicit bias means it's unconscious. You're not even aware that you have it. And of course, by the way, we all have some implicit or unconscious bias about something, right? Like all of us are a part of this. What we're saying is that to the extent that it impacts care, and especially in our space around care to moms and babies, we need to understand that we may have it and understand what to do about it. But can you give specific examples of where you maybe seen it show up in terms of the care that patients have been provided? Are there examples so people understand, oh, I didn't even realize that may have been coming from my implicit bias?
Yeah, and like I discussed before, the idea of coming late. So as a resident, we have resident clinics where we serve majority of Medicaid patients, patients that are underserved. And I remember being a first-year resident, I'm 2 months in, a patient rolls in late about 2 hours, we're about to end clinic. And my chief, so I'm a first year, and this is basically my chief resident, is telling me that I cannot see her because she is late and she must come back another time. She should have been here earlier. And I remember being very disturbed by that. We're all in clinic, we're still here. There's enough residents to go and see this patient, but she thought as though this patient should have, well, somehow must have just came late purposely, thinking that she was going to be seen. I went ahead and saw the patient, being the person that I am, and recognized that she was there with 3 of her children. She again had to take two buses to get to where to our clinic, and then the transfer was late. There was a lot of reasons why she didn't make it. She had loss of childcare, which is why she brought all of her children to her OB appointment. And this woman needed to be seen. She was pregnant. She is extremely high risk, but because of my other co-resident's bias, that she should have been able to get here on time like everyone else, she was very close to not getting the care that she deserved.
Stacey, do you mind responding to that?
Yes.
Yeah.
Go ahead, Joy.
Just a couple of things. You mentioned implicit bias. And so we do all have biases, but we don't have to have them around Black people, around gender, around obesity, around age. So those are all biases that come from our history that we have not had an honest conversation around as a country, that come from the media. And so that's why we have to have these trainings, because if you were trained to believe that people who are poor or Black should not have children, right? If the media is telling us that you shouldn't, if you don't have enough money, then you shouldn't have children, even your chief resident, when that person comes in, even if they don't think they did it purposefully, they think that they should not have children if they can't afford to be on time for their visit. So the way bias shows up, that even if it's a purposeful act, even if they don't believe consciously that the person made a decision to show up late, they do believe people who cannot be on time or people who are not wealthy should not have children. And so that is the bias part. That's where it comes from, a higher, it's ingrained in us that we have this belief that only rich, wealthy white folks should have kids. And it plays out in our policies, it plays out in how we provide care. And I know a bunch of people who are not wealthy, who are great parents, who are amazing parents. And I know people who are working 3 or 4 jobs, we don't provide paid leave. We don't provide opportunities for people to be able to make doctors. We don't provide telehealth until now. Magically, we can do it during this pandemic. So we create barriers to a person like you're mentioning, Talia, being able to get care, but then we see, our bias tells us to blame that person. So that's what we have to undo.
Thank you for that. And that's exactly right. And I was going to go to Dr. Kimberly Jeffries-Leonard, but Kimberly, if you just allow me, I'd actually like to go to Nina first. And Nina, you've written a lot in ProPublica, and again, investigating a lot on maternal care and preventable deaths. You actually wrote an article about nothing protects Black women from dying in pregnancy and childbirth, not education and not income, not even being an expert on racial disparities in healthcare. I'd love for you to talk more about what you wrote in that article and talk a little bit about what you saw in these issues around maternal care and the biases and the racism and how it was playing out with respect to maternal mortality and morbidity.
Okay. Thank you so much for having me. It's really a pleasure and an honor to be here. So the piece that you referenced was a piece about a woman named Shalon Irving, who was a researcher at the CDC. She studied racial disparities. She was exactly the person who you would think would never be likely to die as a result of complications of pregnancy or childbirth. She had great education. She did a great job. She worked at the CDC. She had the best health care. She had a really powerful village, great advocates. She knew exactly what to do. She wrote the book on what to do, in literally in some places. And she still ended up dying from postpartum symptoms 3 weeks after giving birth to her first child. And what her story shows us are some really important things. First of all, she is very much, the CDC has found that, in fact, education and socioeconomic status are not protective for Black women. In particular, in fact, Black women are who are high, well-educated Black women are 5 times likelier to die from complications related to pregnancy or childbirth than white women are. And in New York City, Black women who are highly educated have been found to be more likely to suffer life-threatening complications of childbirth than white women who didn't even graduate from high school. So there's this really important thing there that is critical to understand. And a big piece of what that thing is what Joya and everybody's referred to already around weathering, around the stress of being Black in this country, in this world. To be a high achieving Black woman is in fact incredibly stressful in ways that are not necessarily worse, but they can be different than being a woman who is a lower income woman. They're different stresses, but it's the same underlying problem. The other thing though, then you have to add in is what happened to Shalon Irving was really also an example of another really important problem, which is that our system is set up to take care of women, to do a relatively better job, as poor as it is for many women, to do a relatively better job of taking care of women while they're pregnant and while they're in the hospital having a baby. Where our system really fails women in general, and Black women in particular, is when they go home. And so that's what happened to Shalon Irving. She had, in fact, chronic conditions that made her pregnancy high risk and quite complicated, but she came through childbirth very well. She went home and then it was downhill from there. Another problem, she went back to the doctor over and over and over again and was dismissed for all of these kinds of implicit bias reasons that we're talking about. They didn't take her pain seriously. They thought she was whining. They thought she was angry. They just didn't take her seriously. The other problem is another structural problem that we haven't really talked about, and that's about the lack of research on women in general, women who are pregnant, more specifically, and Black women in particular. And so the kinds of symptoms that Shalon Irving was exhibiting didn't necessarily fit all the boxes that her very good doctors, expected them to fit. So she didn't fit the boxes, so they just kind of shrugged their shoulders and said, oh, there's nothing the matter with her. Whereas, so the problem there is, of course, that just by not studying pregnancy at all for many women, but especially for Black women, we don't actually know what pregnancy and postpartum complications, how they manifest very often. And that can be really dangerous. It's important to note that most maternal deaths in this country occur in the postpartum period. In some states, they occur as late as after 6 weeks after giving birth. And then there's the problems that exhibit during postpartum period. If you have had a bad experience in the hospital during prenatal care, guess what? When it's time for you to go back to the doctor or reach out to your doctor, you are much less likely to want to do that because you've been treated badly. Why do you want to go back to somebody who treated you like garbage before? So you're likely to go back you will go back for your child, but maybe for yourself.
And then what's really interesting. Oh, go ahead. Sorry, go ahead.
No. That's Shalon, and then there's like another level. I mean, there's so many. I think that so much of the structural so much of the racism that is in these stories, it's not just interpersonal, it's structural. And so it's really embedded in the kind of insurance system we have. It's embedded in the structure of something like Medicaid, how we care for women after they give, it's just
Yes.
where women give birth, where hospitals are located, et cetera.
So it's interesting that on the implicit bias front, and how that plays out with a patient, even I guess that if you ask any doctor and nurse, are they a racist? They would say, of course I'm not, right? Yeah. But if you've been believing in your life that a poor woman with 3 children struggling with childcare, on Medicaid, with lack of transportation, should be able to show up on time for employment just like every other woman, and you want to punish her that she can't because these structural challenges she's got to deal with in her life, that is creating a system of care where everyone's not able to get the level of care given the situation that they're in, right? And that requires all of us to look at people for who they are, that everyone doesn't come to the table with the same resources and capabilities and skills, and that we have to have a system that can meet people where they are, all the way to a level of structural policy change, like what you were mentioning around Medicaid, that really actually makes it even more difficult if you get dropped from Medicaid 60 days after having the baby and you have these chronic health challenges. Not even being able to seek the care that you need is a structural problem that has to be fixed. So I think, Nina, we'll come back to that. I think that was a really good point that you made. Kimberly, you're the head of LINCS. LINCS is one of the most influential Black women organizations in the country, in the world. You've made maternal health a priority in your administration as the president. Tell us why you think this is so important for an organization of your influence to tackle this issue, and what do you see as LINCS's role in addressing some of these challenges?
Well, first, I want to also thank you, Stacey, for having this forum and inviting me on. I think it is, I'm very honored to be here, and I want to thank Merck, and I'm just really excited to be here among these distinguished panelists. It's a priority for our organization for every reason that our panelists have said. When you talk about the statistics of Black women dying from maternal health issues, the numbers are staggering, and it transcends socioeconomic status. It really is because we're Black, because we're women of African descent, and every one of us in the LINCS Incorporated, a woman of African descent, has been touched by racism in some way. And these are the things that really are some of the modifiers around the issues that we're seeing in maternal mortality and maternal the numbers for Black women. Every one of us has a story. And I think that when we talk about issues of implicit bias and racism and how they impact the care that we get, it is pervasive. And you don't have to not be of color to have these stereotypical ideas. When I was in my postdoc, I had my first child, and my husband at the time was, I think, a lieutenant and a captain in the fire department, and came home from work to take me when I was in labor. And we went to the hospital, and I was greeted with, okay, you got a husband coming? I'm like, he's right here. And they're like, but because he was in uniform, they thought I was a single mother coming in from an ambulance. And that was kind of set the tone on how they started to treat me. And when I said, no, this is my husband, I'm a postdoc here, and it just kind of changed. So we come into these things with these perceptions. So for Talia, if the mom had come in and had been another color and had been 2 hours late, she probably would have gotten the benefit of the doubt. Oh my goodness, something happened at work. She got held up. But we don't do that. And those are the things that set the tone and impact the care that we get, that see us throughout our pregnancies. And so I think that for us as members of the LINCS Incorporated, because we know that these are issues, it's important for us to be able to put these kinds of programs in place that not only help with policies, because if you have policymakers who think that because you're of African descent, you may not deserve the kind of support. I mean, when you have a lawmaker saying that, you know, we are at risk for coronavirus more because we don't have the best hygiene as Black people. I mean, these are the things that we have to overcome. If we can do something about that as an organization of over 16,000 women who have influence, then that's what we need to do. So our job is partnering with you, which is a phenomenal partnership. Our program is called LAMS, Links Assisting Moms to Be Strong. Then we can use our voice to ensure that they are policies that are not going to impact us just because we're women of African descent, that there are programs that we can ensure that we're reaching out and we're providing the kind of support to help navigate someone through that system, and that we can ensure that a woman who needs it can get the kind of maternal help that she needs. Because you know, I love the title, Healthy Moms, Strong Babies. That is the future for us. Definitely. And so that is why it's so important for us as an organization to be a part of partnering with March of Dimes and to be able to implement this program.
Well, I want to thank you, Kimberly, and I really want to. We're getting some questions in on Facebook, so I want to make sure we can get to some of them. And I'm gonna. There's one question around what can be done if we are not clinical, like if we're not in the healthcare sector. What can we do to tackle some of these issues? And I just want to preface this. Maybe we can tackle it two ways. One is I think it's important to understand, you know, and we certainly look at this at the March Times. When we look at our health generally, only about 20% of it is really addressed in a clinical setting in a doctor's office. About 80% of it we find it really comes in how we live. It's the kind of housing we have access to, the kind of transportation, the kind of income that we've got. And a lot of the things, we call those social determinants of health, and those social determinants really have a big influence on the quality of our health and wellness every day. And so I think this question of what can be done what can be done outside the clinical setting, what can be done in the clinical setting to actually start to make these changes. So what can be done outside the clinical setting? What can we do from a policy perspective, or what can we do to address some of these other systemic challenges that exist in communities of color to start to change this? And I don't know, I'll go to Joya first to see if Joya, you'd like to chime in on that.
I do want to jump in because I'm excited about it. I love thinking about the between what Nina said and what Kimberly said. So when patients, historically, when patients come in and they, like Kimberly did, and she had her husband there and made an assumption that she was a single parent. What we have done in many communities and say, okay, well, I'm not like those other people. I'm here with my husband, and you should stop shaming me like you shame those other people. So what all of us can do collectively is not shame anyone, to not say you should be deserving of things just because you have a husband. But if she had come there by herself, and if she were a single mother, that should be irrelevant. And this is a new point. We don't need the perfect person. We don't need the perfect Rosa Parks. We don't need the perfect, we as a community need to really believe that health is a right. So what I'm advocating for is for all of us to really advocate and be policy to this. If nothing has come out of this pandemic, if we can't come out the other side of us agreeing that everyone is deserved, that everyone is valuable, that everyone should have health. And that means that how we get to that, right? Like how we are the only industrialized nation that has not agreed that all people should have health. We're really literally the only one. Every other country has agreed to that. How they get to it is all different. It doesn't mean the mechanisms are all different, but we haven't agreed to it. So I'm hoping that if you are not clinical, you will fight for policy and for advocacy to make sure that all people have the right for health.
Can I jump in here too? Thank you, Joy. Please. And I think that as we look at those kinds of policies to ensure that everybody, that health equity for everyone, then we got to look at what are the different barriers that keep different communities and different from getting that, and then make sure that we're able to eradicate through other policies, because everybody doesn't have the same barrier. We want to get to the same end, but the way we get there may be different because the barriers are different. And so we want to make sure that we're looking at things. I mean, when we talk about appointments in the middle of the day, if I leave it to go to an appointment in the middle of the day, that means I got to leave my job. If I'm on a job where I'm getting paid by the hour, then I'm going to lose wages. All of those things play into these things. So So we have to look at what we do to ensure that we're moving those barriers out of the way so that everybody can get to that health equity that Joy was saying at the end of the road. And that's going to be very important. So really a deep
even
dive.
Policy issues, not even just around Medicaid or, health insurance it provides the right coverage, but also things that affect access, like transportation, like paid family leave or paid leave, so you can make some medical appointments, things like that. Nina, in your reporting, did you identify other sort of systemic policy opportunities that, if addressed, could help to improve these issues as well?
I think that a lot of these issues really do go back to insurance access. And so I want to say, I think Medicaid pays for something like 45% of births in this country. And I think that Medicaid is a system that is incredibly important and is structured at the national level to be almost a states' rights kind of a program. It was created to give states the maximum amount of ability to take the poorest care of patients that they wanted to, basically to let them do what they want. And in the South, that has meant that women in particular, but that there's very low rates of the barriers to getting on Medicaid are enormous. For regular Medicaid, for pregnancy Medicaid, women drop off within 2 months after giving birth in most of those places. And for a lot of women, that's really, what is the safety net? It really becomes a cliff. And so really understanding how Medicaid actually works. And I think that it's fundamental to kind of do something that's really basic. But it's something that we really haven't done, which is to talk to people and understand their experience of these systems and amplify those stories and keep doing it over and over again. I think that those stories are we would think would be really obvious, but they're really hidden and they're profoundly important. So I'm a big believer in the power of listening to women and using stories to change policy. I think it has been effective in the past, and this is an area where it really needs to happen much more. The other thing, I think, the other people who have to tell their stories or understand their stories are healthcare systems and hospitals in particular. So hospitals, one of the really shocking things about the reporting that's happened over the last few years by me, my partners at NPR, my partners at ProPublica, and other reporters, is to discover how unprepared many hospital systems are, healthcare systems in general, hospitals in particular, for maternal complications that are just like a normal part of a pregnancy and childbirth and the postpartum period. And and they're unprepared, and they don't have basic policies in place to deal with expected complications like hemorrhages, like hypertension, like blood clots, like heart problems. And so putting those policies in place is unquestionably what we should be doing around the country, and that surprisingly still hasn't happened. The other thing, though, that's more hidden has to do with data. Hospitals need to understand, and doctors, and they're scientists. Doctors and midwives and nurses are scientists. They believe in data, and they need the data to understand how their systems are failing and then what to do about it. And so just measuring the actual way they deal with patients around in very basic ways, and then amplifying that information and using it. That's what really needs to happen. That's
a great point. We have a few questions, and I want to try to do some rapid fire, getting some questions and some answers out in the remaining minutes we have. Talia, I want to go to you though, because you got a thumbs up from somebody who asked, did you get written up for overriding your superior when you decided to care?
I don't think my superior knew that I was going to see her. So
I did it on the down low. Okay, well, good for you. So tell us more about what you think can be changed or what needs to be different in medical education training, or or health training in general for healthcare workers, whether you're a doctor or you're a nurse, what should we be doing differently in our medical schools, in nursing schools, to start to address this differently?
I think it's really important, and as like a history buff, I think it's important to know your history. And I think that a lot of times when we go to medical school and residency, we kind of start off and talk about, you know, the big research study that happened in the 1950s or 40s, and then don't talk about what evidence they used to get to that conclusion. And I say that because being in Milwaukee for 4 years, it's really upsetting if I go to a new intern and they have no idea the history of Milwaukee. They have no idea why the city is as segregated as it is. From basic points, they have no idea who the community is that they're serving, right? Like if they don't know who they're serving, how can they actually serve them well? So I think that's one of the first step, is to actually know your history and know who you're serving, and then to work on issues when it comes to disparities, and talk about what type of biases, implicit bias trainings in medical school as well as resident education, and then to do it on a systemic level where you are looking at your institution and your department as whole, right? If you need to do a very thorough review and look at your institution, how are you getting rated, like Nina was saying, from your patients of color? How many nurses on labor and delivery are actually of a minority, but you're taking care of 20% of minority patients? Really looking at that information is important.
That's great. We had another question I think was really, hey, Joy, I'm gonna come back to you just a sec. I wanna get another question in really quickly. I actually think you might wanna really answer this too, because this is one that's also specific around COVID and around telemedicine, because one of the things that I think is an opportunity, and this question is really around, is there an opportunity to expand telemedicine utilized during the COVID pandemic to create more equitable access to prenatal and postpartum care for vulnerable women? So Joy, do you want to attack that, and then others can jump in as well?
Sure, for sure. So yeah, we have been advocating for telemedicine for a long time. For people who are working moms, not having to drive downtown, pay for parking, sit for 3 hours just to get your blood drawn is a win. It would have been exciting a long time ago. And I've testified before FCC before about it. Like, this is not a new idea, but magically during this moment, we are now building up infrastructure for it. What I worry about, and many of the advocates in the Black Lives Matter Alliance and others, is that it's not going to be equitably built, because just like everything else at this moment, if we don't really center the people who need access, who've been begging for this access long before there was a pandemic, that they're going to then create more inequitable care. And so it's really important, as we build out this telemedicine infrastructure and we look to who needs it, make sure that we don't shame and blame people like the person who came in for their appointment to see Dr. Coney, but that we really say, how would she get care? What will we do to make sure that it's easier for her? We're not creating more barriers for her. And when we brought up the hand washing and the history,
yes,
from the Flexion report, that was really from the 1920s. It said that Black people were having more illnesses because we were less hygienic. But we have many data studies that show that 80% of Black folks wash their hands more often all the time. We are actually super, super into being cleanly. We've been cleaning up other people for generations. So this idea that we're magically not hygienic and that's why we have illness is deeply embedded in history of racism. So when you repeat that out loud, you're repeating maybe something you were taught in medical school that was always a fallacy in the first place and based on racist ideas. So we should stop repeating it.
Very good.
I just want to jump in though around the telemedicine question, because it's come up in my reporting. And I think that the assumption is that lower income women are going to have access to a phone, at least, right? It's kind of an, and honestly, that's not true. It's just over and over and over again, I've seen in my reporting that women may have a phone, but it's not the right kind of phone. They may have a laptop, but it's not up to date, or they don't have access in their own homes to good Wi-Fi or any place else. And so I think that really it's going to be, telemedicine is an amazing, potentially wonderful tool, but it's also really important that we recognize from the beginning the disparities that exist in access around technology and do something about it right away. Otherwise, the problem will just be bad in a different way.
That's right. And Kimberly and Joy, you might want to chime in on this. There's a question around what can we do, to really be much more of an advocate for these issues? How can we? And there's another question too about how do we hold hospitals and organizations accountable when Black women report that they experience racism? And actually, I'll just that one question of how can we hold hospitals and different organizations more accountable when women experience what is that? What is the remedy for that? First of all, how do women even voice that? Where do they go with that if they experience it? And what is the remedy for that? And Talia, I don't know, or Joya, I don't know if you want to chime in. And then I'd like to go to the policy question too, and how we advocate for change. Kimberly, I'd like you to pick up on that.
Yeah, we've been worried a lot about this because as we build out these respectful maternity care models, as you know, we've been working with the American College of OBGYN to create a respectful maternity care module that requires some type of redress, accountability. So you need a system of redress. And we have not built that system in the United States around healthcare. There are hodgepodge ways, and I'm sure in Nina's reporting, she's come to situations where people can call a nurse manager, or they know that there's a number maybe on some wall somewhere that you can call, but we have not really ever really created an infrastructure where patients know what they can do if something bad happens. And imagine if you are a Black patient in a hospital and you're treated poorly, and it's not readily available to you to know what to do. Then you have to ask the person who treated you poorly, like the power dynamic is off. There are usually nurse managers that you can write a person up through, as there's also usually a patient satisfaction survey that's available. The Joint Commission is kind of the big overarching body that most hospitals have accreditation under, and they're doing a lot around looking at implicit bias and looking to hold systems accountable. So we're trying to build that infrastructure, but we do, and just like the telehealth, I don't want us to build that infrastructure without actually talking to patients while we're building it, because we're going to once again build a system for redress or accountability that currently is hodgepodge and mismatch and doesn't exist. And we would do it in a way that doesn't include the actual patient's needs. I don't know, Talia, if you have any thoughts around that.
Yeah, I agree with you. And I just, as of right now, I was thinking, like, what can a patient do, right? If they have what exactly can one of my patients do to address this concern other than writing it to a nurse manager or sending in a letter to the hospital? But beyond that, like, how do we actually keep the hospital accountable to ensure that that person who made that act actually gets the discipline that they need? And the answer is that right now, in a lot of systems, there is none.
Yeah.
So maybe that's a policy opportunity. We're about at the end of where we are. I just want to say that Congress has really been active in this space, and so have some of the states. California now is requiring implicit bias training at the state level. Every state should require that, right? That's also in some of the federal legislation that's being proposed, as well as a whole momnibus slew of bills that are now part of addressing these issues of maternal health, including extending Medicaid, 1 year postpartum, and a whole range of other things. So just know that members of Congress like Congresswoman Lauren Underwood, Congresswoman Alma Adams, Congresswoman Robin Kelly, a whole range of folks, and on the Senate side, Kamala Harris, Cory Booker, a whole range of senators have been very focused on this, and there has been bipartisan support. In 2018, Joya and I testified on the Hill in support of the Preventing Maternal Deaths Act, which created an opportunity to start in every state these MMRCs, Maternal Mortality Review Committees, to allow us to collect the data. That point was made earlier. If we don't collect the data, we really don't know where we are on these things. So your advocacy, your voice is really important. Kimberly, you have 15,000 women that could storm up to the Hill today if we wanted to. Should we do that? Are we ready for that?
Well, I don't know if I think we are ready for that. I think, right now we're on the cusp of some major changes, period. And I think that it's when we start one change, it's much easier to continue to make changes, especially when you talk about changes for those people who historically have not had anyone really advocating for them in a way that is going to so that you can actually see change. So yes, the time is now. We certainly don't want to see any more mothers dying We don't want to see any more babies dying. We want to be able to make sure that that legislation that you at March of Dimes have so helped us see what is really important when we look at what we need to get behind. We have been very vocal, our members of the Links Incorporated, around putting our voice behind those things that are going to be advantageous for our communities. And these kind of things are these kind of policies are advantageous for our communities. Our role is to support these policies that are going to, change these outcomes. And our role is to provide that kind of support on the ground to mothers to help them advocate for themselves. That dynamic is very real that Joya talked about. Who do we go to? And it doesn't matter who you are sitting in that seat. If I'm dependent upon you for care, or if they're telling me, well, that's just the bedside manner, that's
right.
just, that's what they do, then we think that's okay. We think it's acceptable, and we may not even realize that there's other things that are coming into play. So our goal, our job is to not only support from a policy perspective, from an advocacy policy perspective, but our goal is to be able to support moms to understand what their rights are, what they need to be asking for, and what they need to be demanding in terms of proper health care and proper
education,
service.
Awareness, and policy change are all
Absolutely
critical. Good. Well, listen, we are out of time. I want to say thank you to all of you all. You've been all amazing, and so thankful that you are here. I know there were a bunch of links that were put in the comments section. So if you want more resources, want more information, here's another slide. You can go to March of Dimes, links, Joya's organization, the Birth Equity Collaborative, Black Mamas Matter Alliance. She was also a founder of that. The Black Maternal Health Caucus, as I mentioned on the Hill, has a whole set of legislative solutions. And then what I've written, what Nina has written. We didn't talk about the New York Times whole expose on why Black mothers and babies are in a life or death crisis, but also the 1619 Project actually points to the history of the lack of healthcare access in this country. And I point you to all of those things are really helpful. I just want to leave with this. We're all struck by the issues of George Floyd and Breonna Taylor, and all of the names in the news that we've been very focused on, for rightfully so. And I would say every day there are unnamed women and unnamed Black people that die at the hands of a system that does not treat us because of our skin color in the way that it should. And that is simply not tolerable and should not be acceptable or accepted by anyone in this country. And it's our job to fight this at every point and every moment that we can, and not do it just when it's in the news, but do it every single day. And that's the whole point of having this. We will have a part 2 to this. We think we've got enough people saying we need to talk more about it. We're going to have part 2. So look for that in the future. Again, thank you all for coming, our great panelists. Thank Merck for Moms for their great support, and we look forward to seeing you all again next week. And thanks for being with us today. Take care.